So this is a patient, 28 years old male, who came with a complaint of inability to open the mouth since past 5 years. He had an history of facial trauma 8 years back, for which he underwent ORIF of left parasymphysis and right zygomaticomaxillary complex, and IMF was done for bilateral condylar head fracture. Coming to the extraoral examination for this patient, he had zero mouth opening and no jaw movements. Both the sides, that is bilaterally, preauricular swelling was present. On palpation, the swelling was boniform, non-tender and non-fluctuant. On intraoral examination, maxillary anterior teeth were missing. So this is the video of that patient where you can see anterior teeth is missing and also there is no mouth opening and jaw movements. This patient also had mastication difficulty. He is barely able to open his mouth and able to masticate. Coming to the radiographic examination, in OPG, we can see dental implants and also plate and screws which is placed. And in the condylar anatomy, the anatomy is altered and also there is fusion of the condylar segment with the glenoid fossa. Coming to the CT scan, we can see the lateral condylar part is fused to the zygomatic arch and also to the lateral portion of the glenoid fossa. And you can see the medial condylar part, that is the residual condyle, is still intact with the space between the above glenoid fossa.
On 3D CT, we can appreciate the ankylotic mass that was present, as we can see that it has overgrown and abutted and actually grown over the zygomatic arch on both the sides. We suspect that this is the preauricular swelling that was present clinically for the patient in the preauricular region. Coming to the diagnosis, we would diagnose this case as bilateral temporomandibular joint ankylosis and classify it as type A2 according to He et al. Classification given in 2011. So according to this classification, type A2 signifies a bony fusion on the lateral side of the joint and a residual condyle that is bigger than half of the condylar head on the medial side is present. So this case correctly fits into this classification. Another new classification we would like to add here, given in 2020 by B et al., which is called as a CDA classification, where C denotes the extent of condylar involvement in ankylosis. So C0 is only the lateral bony ankylosis that was present. Then D0 means the dentofacial deformity, as in this patient, ramal shortening is not there. There is a relatively good facial symmetry of the face as well. So we would classify it as having no dentofacial deformity. And AA signifies that it's an adult patient, whereas AC in the classification signifies as a pediatric, that is in child. And they have also suggested treatment strategies for different types that they have classified. So according to this classification, they have advised lateral arthroplasty by preserving the medial portion of the residual condyle, no intervention for dentofacial deformity, and no growth concerns also, as it's an adult patient. So coming to pathogenesis of TMJ ankylosis, as we know that this is a trauma-induced TMJ ankylosis. So trauma to the condylar heads causes hemarthrosis within the joint, which leads to intracapsular hematoma due to disruption of the periosteum as well as the capsular ligament, and formation of hypertrophic bone occurs, which leads to hypermobility of the joint and resulting in temporomandibular joint ankylosis. So factors contributing to the ankylosis include age of the patient. It is more prominently seen in children, but in adult cases also, especially in traumatic cases, it is well reported in literature. Site and type of fracture, as we suspect the patient would have had intracapsular fracture. Intracapsular fractures have more tendency of undergoing temporomandibular joint ankylosis, and also depending on the extent of displacement of the fractured condyles. Length of immobilization, as the patient was treated by intermaxillary fixation, we expect that prolonged intermaxillary fixation after dicapitular fractures leads to ankylosis of the joints. So that must have been a contributing factor in it as well, and damage to the meniscus. So in case there is any tearing of the disc of the joints, it leads to direct contact between the glenoid fossa and the condyle, leading to ankylosis. So all of these would be the contributing factors in this case. An article by He and Ellis et al. It very well describes what is the etiology in traumatic joints leading to TMJ ankylosis, and it also tells us the role of concomitant mandibular fractures, which is especially important in this case. They have suggested in this paper, excuse me, that any cases of sagittal fractures of the condylar head leads to lateral displacement of the lateral poles of the condyles over the zygomatic arch, leading to TMJ ankylosis. They have also suggested that the role of the concomitant mandibular fractures is during open reduction and internal fixation of these other fractures. It may be a symphysis, parasymphysis, or a body fracture. If that fractured segment is not reduced properly and fixed, that may lead to widening of the mandibular arch, which leads to the lateral pole of the condyle or the condylar stump to become displaced laterally or superolaterally in relation to the zygomatic arch, wherein it fuses with the arch and causes the temporomandibular joint ankylosis. So this was a picture that was of the CT coronal section given in the article, showing the kind of trauma that could lead to such a case. And this is the presentation of this case, where CT coronal section quite well replicates and shows that this might be the case in this case as well, leading to bilateral TMJ ankylosis. So coming to the treatment options, we would advise that first treatment option would be lateral arthroplasty. Second option would be interpositional gap arthroplasty. Why not gap arthroplasty? Especially in cases of bilateral TMJ ankylosis, gap arthroplasty has a few disadvantages. First is need for joint reconstruction, because it will in turn lead to a decrease in the ramal height. To have a functioning joint, we would have to go for joint reconstruction in the later stages. Re-ankylosis can also occur after gap arthroplasty because there is no interpositional material in between. Loss of ramus height, as I suggested, because of removing a big chunk of bone that we take it out, that is the ankylosed segment. Then malocclusion, and also is, since this case is bilateral TMJ ankylosis, it can also lead to obstructive sleep apnea. So advantages of lateral arthroplasty, which would be the first treatment option, is that it preserves the functional residual condyle. The residual disc on the surface of the condyle also helps to prevent the recurrence of ankylosis, and existing ramus height can be maintained, and it avoids the reconstruction. Hence, it is also economical for the patient, because reconstruction again leads to excess cost factors coming in for the patient's treatment. That's our presentation. Thank you.
Thank you, Soundarya and Sakshi.
Thanks.
So, over to our panelists, Kanan sir and Jagannathan sir.
I would like to just intervene here, sir. I think Lakshmi madam
Yes, sir.
hasn't
Yeah,
informed.
Doctor.
Jagannathan is quite, he is apologetic that he is unable to be present here today. He had some other thing, and he apologizes for that.
Okay. So you will be representing him, huh?
Yes, I'm Dr. Amarnath.
Most welcome. I know you very well. Most welcome,
Yes, of course.
Amarnath.
Yeah.
Yeah.
I'm a professor with sir at Mumbai. So I thought I'd just
Please continue.
apologize on behalf of sir. Yeah. Kanan sir, any questions?
Kanan sir, if you could ask.
Yeah, I gave the case, so I would say you start off and then I will follow up with the.
That's fine. Yeah.
Discussion. So the case was from ours.
Yeah. in the diagnosis, Saundarya and I think they mentioned
Archie.
about the classification. Do you know of any Indian classification for TMJ ankylosis, maybe more relevant to our times, and which also I think your case fits into one type of that classification?
So Shawnee's classification, sir.
Yeah. So what type would your
Type 2, sir.
case? Yeah. So what's type 2?
So lateral part of the joint is ankylosed and the medial part remains intact. It is not
So
fused
can
with
you
the
just
bony
put
skin.
up your CT scan picture? I think very relevant. The classification that Dr. Sahani sir has described uh, is sort of a graded classification, and it quite, I think the CT scan pictures that you have quite beautifully bring out the type 2 of Sahani sir's classification.
1 second, sir.
So it's again some problem with the slides.
Okay, as you are doing that, you were also discussed about the pathogenesis of the ankylosis, right?
Yes, sir.
Yeah, this is as you can see. If you see the pictures that Dr. Sahani's classification has, this is very classically a type 2 type of or grade 2 type in Sahani's classification. So, as Indian plastic surgeons, I think it would behoove us to at least mention an Indian classification which has stood the test of time and does help us in guiding our management as well. All right. So, in pathogenesis, you mentioned about hemarthrosis and subsequent steps. Do you think that's the pathogenesis here, or the pathogenesis here is something else? The pathogenesis in a what do you think is the difference in pathogenesis with a pediatric case vis-a-vis an adult case? Is there any difference?
Yes, sir. In especially in pediatric cases as opposed to adult cases, first thing is coming to the very basics is the anatomy of the condyle, sir. Pediatric anatomy is fairly different in pediatric cases as opposed to adult cases, which in turn leads to difference in etiopathogenesis of the condition. So a pediatric condyle has a thinner cortex, and it is also an actively growing joint. So, and also has greater vascularity, which in turn increases the chances of any trauma to the joint leading to an ankylosis. Whereas in
See,
adult,
whether it is a pediatric case or an adult case, we all know that the weakest part of the bone is going to be there. So
yes,
fracture occurring in the region, in the condyle region, the neck region remains the same. So what are the additional factors in a pediatric case or in a child which lead to ankylosis? Suppose 100 kids get fractures in the condyle and 100 adults get fracture in the condyle. Would you agree that more kids will probably develop ankylosis given a
yes,
chance? So what are the reasons in a pediatric patient that causes this?
So one is the growth potential,
Yes.
the condyle.
Yeah.
second would be the thin cortex over the condyle,
Yeah.
which
So
can
in a
readily
pediatric
fracture.
case, what part will be fractured? In an adult case, what gets fractured?
Right, sir.
Yes, sir.
Sir, adults more commonly neck fractures are present, sir.
Exactly.
Whereas in a
Exactly. Yes.
pediatric case, there is more bulbous anatomy of the condylar head.
The neck is
leading
still
to
not developed.
fracture.
The neck is still not developed. What you have are intra-articular fractures. The head itself gets fractured. There is a high osteogenic potential. Many times these fractures are not detected. The kids are unable to explain what they have. They tend to keep their mouth closed. Physiotherapy is a problem. So you can have, while an adult, as you yourself said, you yourself pointed out, what fractures in the adult, what do we describe as the weakest part of the mandible? In most
Neck.
percentages, what do you say fractures?
Neck of the condylar.
Neck. So do you think in a neck fracture you will have the same course, hemarthrosis leading to all that? Is the neck intracapsular or extracapsular?
Extracapsulars.
Right?
Depends
So
on
do you
the
think the same pathogenesis will apply in an adult as well? The pathogenesis that you just described, the sequence, the steps that you described are classically seen in a pediatric condylar fracture, right? While
Yes.
in an adult patient, the other factor is more important. The type of, the length of immobilization, and I think the length of immobilization is the most significant part in an adult patient. There is one more thing in an adult, which is rare, but which can also sort of lead to ankylosis? Can you think about something like that? Any condition, any innate condition in the adult which can cause ankylosis, not only in TMJ, in other parts of the body as well?
Spondylosis.
Sir, any osteoarthritis of any
Yeah,
other
some ossification disorders. There are ossification
Any-
disorders. Some patients, it's rare, but it can happen. The other thing in adult could be extra-articular ankylosis as well. You also have to keep in mind extra-articular ankylosis. What we usually or most commonly talk about is intra-articular ankylosis, but there could be extra-articular ankylosis. I think in your patient, what has happened is the condyle has fractured and both condyles has fractured in the neck, and both of them have sort of, the medial deviation has occurred, which is quite apparent in the
Yes.
CT scan. You have an angulation of say 30 degrees, and then at the fracture site, you have developed the fracture site has then got fused with the zygomatic arch and the glenoid fossa.
Yes.
All right.
Can I just make a comment along with the same lines, Dr. Amarnath?
Yeah, sure, sir.
So in an adult, like what he asked was a pertinent point in the sense what classically describes is because, as you said, bulbous head, everything is vascular and everything communicates. Whereas in an adult, you can see it in the CT as well, in the picture which you have put. There is a dicapitular fracture. It's a head fracture, whereas in this case, as it is, which is common in two-wheeler accidents with the symphysis as well as the bilateral condyle. And maybe the neck is not gone. So the medial part of the head is fractured and moved inwards, and the lateral part is expanded out. So there is a flaring of the mandible. So this lateral part is going and rubbing against the zygomatic arch directly.
Yes.
So it is not sitting under the arch, and there is bone-bone contact. So when the condyle comes off laterally, your disc, everything is more medially gone because there is a medial fracture as well. There is a good chance it might be bone v bone, and then immobilization, like patient not cooperating or because of pain and not mobile. Either we have not reduced it fully when you are fixing the symphysis. So when you are addressing the symphysis, we have to ensure that we are trying to get the condyle into position. One way is some people might say put a very rigid plate in the symphysis so that it doesn't allow flaring. When you are reducing itself, you need a bigonial pressure to get it into the fossa. And then look at immobilization or early mobilization. Dongmi, he whom you put, she's a big proponent of fixing all these fractures to make sure that they are one single unit. But the more important thing which they don't address is getting the condyle or head into the fossa. Without that, your ankylosis would have happened. So if you had told that to Dr. Amarnath, then it would have been easier. Sir, in this case, this would have gone like that. So you can see it in the picture you have put. It is going and touching the ramus.
Yes.
So
in
you
terms
have
of
seen
clinical examination, yes, sir, please.
No, please go on. Please go on.
So clinical examination, you have commented about mouth opening. Could you assess his or any what occlusion he has? What's the molar occlusion like? Anteriorly, there are no teeth. What's his molar occlusion like? Any idea?
Sir, only can be seen on an OPG, sir, with
Okay, you don't have the photographs.
photos that were provided.
Okay. All right.
So this
Sir,
is
just describe this. Suppose this patient had come to you primarily. What would you have done, or what could you have done, sir? Just describe it, but to avoid such a complication. So, what steps would you take in a patient who has this type of, they call it Gardner fracture? You have a symphyseal fracture with a bilateral neck fracture or bilateral condylar fracture. And in addition to that, you have slight subluxation at both joints. So, how will you avoid this type of complication in your patient?
Yes. The first option would be, as was treated in this case, that is only addressing the parasymphysis fracture, whereas doing a close treatment for the bilateral condylar fracture is one option, but it would require rigid fixation at the parasymphysis. While reduction, we have to make sure that there is pressure on the gonial angle so that the laterally displaced portion of the condyle is again repositioned into the glenoid fossa. And post-operative aggressive physiotherapy is required as opposed to IMF fixation, sir. Intermaxillary fixation should not be done. Secondly, we can go in for an open reduction and internal fixation of all the fractures there, or at least one of the joints.
as we just discussed, what type of fracture would the two condyles have?
Sir, dicapitular fractures.
Intracapital fracture.
Intracapsular.
So, what's your plan of fixing at least one? You said, how would you fix an intracapsular fracture or intracapitular fracture? Do you
Sir,
think you need fixation in intracapital fracture?
Yes, sir. Sir, usually if depending on how the fracture is, sir, if it is, we are suspecting that in this case, there might be two segments to it. That's one as the
Yes,
medial and the
yes,
lateral one. So
yes.
with a lat screw, we can fix the head fracture, sir. Or with any long bone screw. But ideally, lat screw is usually used, sir. At least one joint, if it is fixed. There are a few papers in literature which state that at least one should be addressed. But nowadays, the ideology has changed where they advise to go in for open reduction internal fixation for almost all condylar head fractures as well. If the segments are reducible, that is not very comminuted fracture. If small portions are there, those can be removed. But with a lat screw, we can fix the head, sir.
I would like to hear
Can I
Kanan
just
sir's
interrupt
views on this. Yeah,
you
Kanan
guys?
sir's views on this, fixing capital
Yeah,
fractures.
Can I? Yeah. Can I? What is the main difficulty in fixing this fracture?
Sir, medially condyle is displaced, so bringing back into position is difficult.
That is
And
not.
also
Is
this-
that the only problem you think you?
So, no, and also the
What
cervical
else you
anatomy we
think?
should consider, sir.
Okay, no, what you're right in the sense you're trying to align, you're trying to identify it, and positioning it is going to be a problem. The entire lateral pterygoid might be attached to it. So when you are in the process of positioning it, what is the other challenge? You have to hold it in position and try and fix it.
Yes, sir.
So lag screw, it won't be easy to fix it. A lot of time they tend to wire it or something. So, but then whatever they have described, I'm just saying, or a headless screw, what is described, not a lag screw will be difficult. But then during that process, what can happen, you think?
Sir,
How big is the fragment? It
Sir,
is not too big, maybe 1.5 centimeters max or less than that. So you have to
Sir,
bring it
maybe
on the
more
inside of the
displacement.
condyle. So when you're trying to bring it and reduce it into position, how do you think you'll be able to reduce it?
Do you have
need
a
to hold
counter
it
force?
and
Do you have a
reduce, no?
counter?
Yes, sir.
Yeah,
Lateral
so-
pterygoid is attached to the head.
So
there
when
will
you're
be a
pulling it,
force.
what can happen?
Sir, more medial displacement.
Okay,
No.
pulling it, reduce it. So you have to pull it out to reduce it, no? Pull it more laterally against the condyle, remaining fragment to fix it. What do you think can happen there? Can it come off in your hand?
Yes, sir.
Yes, sir.
Yes.
Then if
can
it
become
comes
a-
off in your hand, then the challenge is it is a free graft.
Yeah, it's an extracorporeal type of
It's
fixation.
extracorporeal.
Yes.
Which might resolve also, and your fixation also might not
No
be
vascular.
that optimal. So you have to be aware of the risks of that fixation. We are
Yes.
seeing this more in two-wheeler accidents when they just skid and fall.
I think more relevant in these type of fractures is to make sure you reduce the subluxation. Remember, if you reduce the subluxation, your height is already still maintained. You have got half of the head still in place. So as you
Yes.
said, maintain gonial pressure, yes. But also remember your fracture is far away from your fracture is in the midline, while the two angles always will tend to splay out. So unless you put a very, very long plate beyond your midline fracture, it's very difficult for your plate or a strong plate to maintain it. So one is overbend the plate. That is one thing that you want the lingual cortices to come in contact, even at the cost of maybe getting slight opening up of the buccal cortex. I think you must have read this concept in books also, where you overbend the plate. The central part of the plate is slightly higher, it's not in contact with the bone, while the lateral parts are slight. This is especially important in these fractures where you want to maintain the gonial distance. One other thing could be is, yes, physiotherapy you said, maybe you apply elastics, post-op, guiding elastics. These guiding elastics will ensure at least the two parts are pulled inside. And it's a sort of a dynamic thing with strong elastics, class 3 elastics. It's sort of a dynamic thing which will make sure that the vertical fragments come back in place or they stay in place and they do not tend to ride out as they have done post the trauma. One absolutely different thing where the patient is not what we have tried is to make dental models, reduce the models, and make a sort of a splint that you would use rather in pediatric patients, like a circummandibular splint, and put a circummandibular splint in addition to fixation, which sort of gives you that sort of binding effect right throughout the dentition. That maybe helps you to maintain the so the important thing here is reducing the subluxation. And once you reduce the subluxation and maintain post-op pain relief and post-op physiotherapy, you will thankfully or maybe hopefully avoid this type of ankylosis.
I think that's an important point. I don't know if you picked it, whatever you read us. So when you're giving bigonial pressure, see if there is opening up of the buccal cortex in the reduce. So that means the lingual cortex is abutting. That is the ideal pressure. If the buccal cortex is tightly there, you don't know what's happening to the lingual cortex. It is still flat. So just see the gap. As sir said, you just have to see it just about beginning to open up. So that means lingual cortex is there with under occlusion and with the bigonial pressure. So that is the key. One other thing which you guys, how Dong Mai, he avoids the, after fixing, she pulls the disc and resecures it over the jaw, head of the condyle. So without that, then the risk of ankylosis is more. You might not only, if you don't reduce it, you have reduced the fracture, but still it is hitting against the lateral pole, lateral aspect. It's sitting laterally and it is hitting the zygomatic arch and it will still cause ankylosis.
Yes.
So now we have missed the bus. They are here. So,
Yes.
so now what are you planning to do? Now you have lined out plus or minuses. So in your hands, what do you think?
Yeah, so you have
planning?
lined up a few options. What are you going to do with this patient? This patient is in your clinic. He's sitting in across from you. What are you explaining to the patient now? What will you do?
The patient has come primarily or secondarily now with ankylosis.
Yes.
With ankylosis. Yes, sir. So, sir, we can go for lateral arthroplasty in this case, sir. Lateral arthroplasty, which involves removal of the laterally ankylosed mass and medial part can be retained, and post-operatively we will subject the patient to physiotherapy, that is mouth opening exercises and physiotherapy to maintain the mouth opening intraoperatively.
Any additional investigations you expect for that, or you will need for that?
Sir, sir, only for lateral arthroplasty, CT is okay, sir. For
You already
us
have
to
CT.
plan it.
You already
Yes,
have a
sir.
CT in place, yeah.
We can make STL models and surgical guides on that as well, so
Okay.
as to guide our arthroplasty. Along with that, for CT angiogram can also be done in order to visualize the
vascularity of maxillary arteries, sir.
internal maxillary
Or
artery
measure the maxillary artery position, so that surgical guidance will be there. If we are not using any splints or anything while cutting the condyle, we can measure where the maxillary artery is present, and then we can do it.
You
CT
said you want to do a lateral arthroplasty, right?
Yes, sir. In
So the
that
medial segment, you are not going to touch
Yes,
the
we are
medial
not doing
segment.
that.
You still would like, you are still afraid that you might cut the maxillary artery? There is a
No, sir.
block of bone medial to where you are cutting it. I would have agreed if you said you want to do a gap or you want to resect the whole thing.
Yes, sir.
But
If
that
it
is
Then
a
is
it is
nice
more
solid
needed.
cartilage covered piece of bone medial. That is a good indicator of where you are.
Right.
Plus, you want to do the STL models. So, I mean, that should be enough. Subjecting the patient to CT angio may not be really
Yes.
necessary. Plus, I think in most cases of TMJ ankylosis, a plain CT is what is ordered, and that itself gives you an indication how far medial the bony block is. So, in contrast, I don't think adds much info to your this thing. Okay. What approach do you plan on use? And when you say arthroplasty, what do you mean? What will you do? Just tell us the broad surgical steps that you will do.
Sir, arthroplasty, lateral arthroplasty would involve the resection and reshaping of the lateral portion of the condyle, sir. That is, the ankylosed mass will be removed and
Yes.
the residual condyle will be maintained medially, and reshaping would be done of the ankylosed mass. That would entail the arthroplasty.
And your approach will be?
We will also, sir, pre-auricular approach.
the
would be
same
ideal.
as you would go for a temporomandibular joint ankylosis case or approaching at the TM joint.
Yes.
So
Approaching the
what are the what I call pressure points? What are the important endpoints? How you will decide your endpoint? The endpoint on the mandibular side. Remember, when you are within the block of bone, if you don't have a guide, as you say with STL, how will you? There are two things. Either you can cause more injury towards the mandibular side, you can end up fracturing the mandible, or on the proximal side or on the superior side, you can end up going into the
medial.
Middle cranial fossa.
yes. So what are the steps or what are the precautions you will take to avoid both these complications?
Yes, sir. Sir, first we'll have to measure the ankylotic mass on the CT scan that is there with us.
Yes. Yes.
So that will give us the dimensions of the ankylotic mass on each level. We can start right just below the zygomatic arch till the neck of the condyle where we can see that it is fused. So
Yes.
neck of the condyle would be our mandibular extent or the
Inferior
landmarks are
extent.
inferior extent, and
Yes.
superior extent would be the zygomatic arch, which is visible in the operative. Those
Okay.
would be our two extents. Also, we would have to see the depth that we are going, sir, as we are doing the lateral arthroplasty over here. So depth is very important because as this zygomatic arch is very much fused as a big block that we can see on this 3D
Yes.
CT also, it might be
Yes.
very difficult for us to gauge the depth
It
that
might
we
be,
are.
it is definitely
It
very
is
difficult. Once you are once you are in the surgery, once you open the joint, you can't make out what is what. I
right,
mean,
sir.
this is still, you can still see the sigmoid notch. The sigmoid notch is a great guide to have. So you're lucky in this case, you have a sigmoid notch. You may end up with a case where you do not even have a sigmoid notch. So having the lower border of the zygomatic arch as a guide, you can take the superior cut. And
Yes.
if you're lucky to have 3D models and guiding cut guides that these days you have, that's extremely great resource to have. But if you do not have that, then you can start off with marking the lower border of the zygomatic arch, extending it posteriorly, and then slowly with a contouring burr and a fissure burr, slowly burring out up to the bony block at the inferior end. And if you could enter the joint space medially as the first point of time, that sort of then helps you to just control the rest of the bone.
Right.
As I said, if you have the resources and have the cutting guides, that's the best thing to have. But not all people are maybe lucky enough to have that. We don't. So we use contouring burrs. We use the lower border of the zygomatic arch as a guide. And
Right.
as long as you keep your cut exactly parallel, exactly horizontal to the Frankfurt's plane from there, it's very unlikely that you will enter the middle cranial fossa. And then you use burrs and fine osteotomes and do that. Kanan sir, anything else to add in the procedure?
I think that's a valid point, what you have. So only thing to just say is now we also have piezo saws, which helps.
Yes. Yes.
So though it takes time, but the principle is the same. You have to know your anatomy. So because you have decided lateral arthroplasty, it is going to be technically more challenging. You don't want to knock off the medial condyle and make it a gap arthroplasty when you're going. So you can't go too low. So as sir said, you mark at the lower border and then angulate and go into the space, then open up the joint and then start the contour. So it is a tricky one. But then if you get it, then it is nice because you've got a reasonable contour and you don't want to disturb this contour, or you don't want additional procedures to reconstruct this deformity.
Yes.
So Saundarya and Sakshika, could you just quickly go through the access to the temporomandibular joint? What access will you use? Details of the access. How will you? What is the point of concern while accessing the TMJ, which you will also have to explain to the patient?
Sir, facial nerve
Yes.
function.
So, what are the steps you can take? What are the tips you can follow to avoid or minimize as much as possible damage to the facial nerve while approaching the temporomandibular joint?
The guidelines, sir. First is the approach which we are going through, which fascia. Directly approaching or going below the temporoparietal fascia or a deep facial, subfacial approach. So
Okay.
this one we will do, sir.
So which one would you use?
Sir, a deep subfacial, I think facial nerve damage is less. But in case of temporoparietal fascia, immediately the facial nerve comes just beneath the temporoparietal fascia. So instead of subfacial approach, deep subfacial we can go, sir. That is one.
So how long is the incision?
Sir, incision is
You said preauricular, but just a
yes, sir.
preauricular incision is enough, or would you like to have some extensions?
Sir, extension also we can do, sir.
Without extension also you can do, that means?
Sir,
No, with extension.
sir, preauricular incision.
How does the extension help? How does the extension help? Yeah.
Where is the extension
Role
going?
of the extension.
Sir, extension helps to identify the zygomatic arch from the top by giving a oblique incision also. And then a bigger approach, like exposure is quite wide, sir, if we give extension. But in case of preauricular, the exposure is less.
We'll be able to bypass the temporal branch of the facial nerve with an extended incision.
And superficial temporal vessels also.
So that would help us to avoid any injury to the facial nerve that would be
What
encountered.
branch specifically are you concerned about? Most concerned about, I should say. What is the branch you are most concerned about? What
So,
branch of the facial nerve?
Frontal branch. Frontal
The
branch of
temporal or the
facial
frontal
nerve.
branch of the facial nerve. And what's the anatomical or the surface landmark of this nerve?
Sir, in front of the external auditory canal, it is 0.8 mm to 0.8 centimeter to 3.5 centimeter from the external auditory canal, bony landmark. And surfaces, it is just beneath the temporoparietal fascia and also with the Pitangai's line.
Yeah. So
we
what's the
can
Pitangai's
identify.
line? What's the
Sir,
course?
it is 0.5 mm below the tragus of the ear to the 1 centimeter just beneath, just behind the lateral part of the eyebrow. That is Pitangai's line. I think in front of that frontal nerves passes. Sir.
So that's the course. That's the approximate course of the frontal nerve. You
Yes,
should
sir.
also realize that it's not in the same plane throughout. Starting off, it's almost subperiosteal near the zygomatic arch. It's just above the periosteum, not subperiosteal, just above the periosteum. And then as you go slowly upwards, the plane changes. And which is why it's difficult for you to make sure that you protect the nerve if you use only the preauricular incision. What Alkayat and Bramley's approach does is you have an extension into the frontal hairline and you divide the deep temporal fascia, the superficial layer of the deep temporal fascia, go into temporal fat pad, and then reach the zygomatic arch. In that way, you're absolutely certain that you have retracted the frontal branch of the facial nerve in the skin flap. And then you can expose the zygomatic arch. Once you have exposed the zygomatic arch at that level, then you can go below that and expose the bony block and further inferiorly and expose the ramus of the mandible as much as you need, right? So that's the philosophy or that's the principle behind using the Alkayat approach, at least, where you divide the deep temporal fascia and go in above its just where it divides into the anterior and into the two divisions and between the temporal fat pad. Yeah. Okay.
You guys, is there anything you would want to concern the patient apart from the facial nerve, along with them anesthetically? You want to do? How do you prepare the patient for anesthesia?
Sir, intubation for the patient would be a challenge. The regular intubation that we do, nasotracheal intubation, that will be needed in this case. So either we will require a fiber optic intubation for this case, sir. So fiber optic intubation should be awake. Fiber optic intubation should be explained to the patient, and that consent should also be taken so as to make it a smooth procedure. And also in cases, just in case if that also doesn't work, we might have to go in for a tracheostomy. So tracheostomy consent should also be taken if just in case if anything goes wrong
Yeah,
during
it's on the safer side. You might take a consent for emergency tracheostomy in case the fiber optic does not work.
Yes.
These days, fiber optic is done quite smoothly.
Thank you.
Is there any other technique fiber optic? Some guys who might do, some
Hello?
of the guys with fiber optic it become obsolete, but anything else your anesthetist?
Sir,
Some guide wire, retrograde. Some still
yes,
do.
sir.
Have you heard about that technique, retrograde transtracheal?
Yes, yes, sir. We have. Where they go in, the intubation is done through the tracheostomy site, sir, but then the
Just tell
guide
us the
wire
name of
is
the
guided
membrane.
out of the nose and then
Just tell us the name of
nasoendotracheal.
the membrane. I think Farooq sir is eager to start the next case.
At-
Just tell us the name of the
Not
membrane.
bigger. Actually, time is up for the discussion. You can
Yeah.
carry on for 5 more minutes.
Yeah.
So you
No,
can
sir.
carry on. Then we'll ask the moderator to have his comments. You can carry on for 5 more minutes. No issues.
Have you ever seen a retrograde transtracheal?
Not in person, sir, but on videos we have seen, sir.
So instead of fine guide wire, or sometimes I've seen anesthetists use a sort of epidural catheter even.
Yes.
Go through the cricothyroid membrane, direct it into the oral cavity, come out through the nose, and then railroad your endotracheal tube over that.
Yes.
You need a good, not a good, you need a nicely compliant and,
Patient for that.
patient, I would say, a patient
Yeah.
patient for that, who is willing to have, you need good anesthesia of the posterior pharyngeal wall, nice lignocaine spray, and you need a transtracheal anesthesia as well. They usually spray some anesthesia drug into the trachea as well to anesthetize the mucosa. Otherwise, you have a bad cough reflex. The cords are close by.
Our anesthetists also used to use some whistle. Whistle sort of with the guide where they used to put a whistle. And when it goes to trachea, it produces some
You heard the
noise
whistle.
sound. Yeah.
Okay.
These were the olden days when these sophisticated things were not available with us for the intubation.
Blind nasal was some senior anesthetists were very
Yeah.
fond of blind nasal
Yeah.
as well.
In fact,
And they keep on
I
checking
would
the
just like
misting
to
of
add
the
one
tube.
thing to this, that most
Yes.
of the anesthetists are even planning or doing USG guided intubation. Ultrasound
That's
guided intubations are also being practiced now. And very often we have seen that they have asked their PGs also to take up that as a topic, most of the anesthetists. So they are getting very frequently mastered in ultrasound guided.
okay. That's an
Okay.
interesting. We haven't had
Okay.
that here yet.
I have
In my
not seen
center,
yet.
in my center, we have done at least 3 cases with USG guided, and very clearly it shows the tracheal movement and all. But it just need a lot of practice on it.
So
So
yeah,
recently,
there's a learning curve. There's a learning curve to that, I guess.
yeah, 2 of the anesthesia PGs in my unit, they have taken that as a thesis topic.
Okay, that's
So
interesting.
That's great. That's great. So
Okay.
may I request our moderator Surajit sir to have
Thank
his
you for the
comments and questions,
very
sir?
nice presentation. The ladies have presented the case very well. While you are at it, I think the 2 gentlemen moderating them would do good if they can tell them about the role of endoscope in condylar fractures, because these are the stuff which are often asked in exams, and they should know what the role of an endoscope is. The second thing that I would like to talk about is, after we have shaved off the lateral part of the condyle, we are leaving a raw area. Lateral part of the condyle, we are leaving a raw bone. Do we leave a raw bone, or do we do better if we cover it with a temporoparietal flap? 2 things
Sir,
I would like.
it would be better to cover it with some sort of graft material there, sir. Either a temporoparietal fascia, or we can take abdominal fat, or a silicone graft can also be placed.
Silicone sheets.
Or amniotic membranes are also being used these days. So all
The
of these are,
vascularized flap is available. A
yes, sir.
vascularized flap is available, so that
That's
would be
the best.
better.
Yes, sir.
The role of endoscope in intracapsular fractures. And 1/3 of the neck is intracapsular. 2/3 of the neck is extracapsular.
Yes.
So now,
Personally, I haven't had the opportunity of using the endoscope, but I think maybe Kanan sir, you can take that one.
yeah, nowadays, thank you, sir, for the question. Thank you, Ramana. Nowadays, endoscope assisted fixation of the condyle is coming into vogue. It is not fully endoscopically fixable now, as of now. we are trying to visualize. So the approach is through an intraoral route, expose and see, and then you insert endo to visualize and
After, once you have
originally
seen it,
the fixation. Yes, sir.
once you have seen it, then you the medial part, which is which has gone away, which has gone more medially, they try to put in a 1 millimeter K wire and use that as a joystick. And with that
Yes, sir.
joystick, they
Yes,
try
sir.
to bring it out and then try
Yes.
to fix it with the help of
Fix it.
the visualization is by the endoscope, and otherwise it is endoscopic assisted.
Assisted fixation. So that's what is coming into work. So now the head, it will be what if it's not the head, which in the neck, they try and use a 90-degree screwdriver now. So you don't need an external port or anything at all now. Whereas with the
Right.
head, we are struggling. So it is, other than a couple of people for a head, it is a steep learning curve for most of us for head. Routine TMJ arthroscopy, it is a shorter scope, endoscope, which is limited only to visualizing the disc and the anatomy. Whereas fixation is a conventional ENT scope like thing, which is slightly wider, and so it gives us a better visualization.
I think the ladies have done a wonderful job. They have presented this case very well.
Thank you, sir.
Regarding sir's comment of trying to interposition, and they also mentioned it, because there is a condyle stop, and if you give a wide one, sometimes an interposition role is lesser. So, but then literature now we see dermal fat graft have a negative effect on, or let's say positive effect on the results, negative effect on re-ankylosis. So we don't know the correlation than direct fat, but at least literature supports that. But mostly from India, AIMS and thus even in the British Journal, I've said that patients with dermal fat graft, abdomen, basically because easy access, the rates of re-ankylosis in those patients are much lesser.
We can go to the next case, Umar.
Yes, sir. Any comments from the Bhattacharya, sir?
Thank you.
Bishra, good afternoon.
I think good afternoon. Good afternoon.
You want me to just quickly show the result of the case, sir, what we did?
Yes, sir. Please go ahead, sir.
Just 2 minutes
Then-
if you have time. Let me see.
Yes, sir. Please.
I need they need to make me co-host so that am I made the co-host, sir? So let me see. Share. Let me just 2 minutes.
Yes,
Is my
sir.
screen visible, sir?
Yes, sir. Yes, sir. You can make it full screen.
Full screen,
Yes,
yeah.
yes, sir.
Yeah.
Yes,
So,
sir.
so this was the plan, as they said. The challenge in this case, as Dr. Amarnath clearly said, was trying to do a good lateral arthroplasty without damaging the medial pole. The medial pole we saw was a very flimsy one. And so the risk was always it was going to get fractured. And if we miss it, we will end up doing a gap arthroplasty. So this was, we convinced the patient for cutting it because we end up doing a gap arthroplasty is going to have further procedures. So that was our conviction, and only doing a study model and only cutting guide in plastic is less expensive. So on the virtual surgical planning template, this is on the virtual surgical planning template. We got the angle for about 1.5 to 2 centimeters gap of the lateral pole. So the depth was marked 16, almost 17 mm, the top line, which we can on the right. On the left side, more, almost 22 centimeters and 19 centimeters, and we got an angle of 40 degrees or 45 degrees so as to get a good 1.5 centimeters gap, and that was on the software. And again, the software, this is after design of the cutting guide. So in this cutting guide, the slope of this limb guides us to how much to do. So one thing which probably we wanted to do is same, because we are only cutting the lateral pole and not going too medially. We ended up only doing a pre-auricular with a little bit of extension. This is the model post planning with the cutting guide. Retrospectively speaking, sometimes a metal cutting guide is good if you are using a lot of saw and this thing, because you might end up cutting the plastic.
Right.
So that is a challenge. So the cutting guide has slots to fix it to the mandible with screws, and these are them in situ. And then this is just to say we can see the line. This is based on the angulation of the line on both sides. This one, if you see, there is a gap because the cutting guide is broken there a little bit. And so this is the post resection, and just to give us a guide as to the resection mass and its intra-op mouth opening. This is between the canines. So if the incisors, it will be most, and this is a post-op CT.
Sir, we can't.
We
I don't
can't
think
see
we can
the,
see
sir.
the slides.
Yeah, we can't see
Yeah,
the
now we
slides.
can see the cutting guides in place. These
Oh.
are the intra pictures we can see. There is a lag, I think.
Intra-op, is it visible
Yeah,
now?
yeah.
Yeah,
Lag,
the intra pictures are seen, sir.
My net. Now intra-op is seen,
Yeah,
sir?
intra-op.
Okay.
Yes, sir. This is post-op radiograph now.
Now we have the, so the resected mass, just to give us for comparison, and this is a model with the blocking of teeth. Can we see the intra-op mouth opening, sir?
After that, this it will come after this slide. You can move to next slide.
Now I am in post-op radiograph.
Yeah, yeah. This is
But
the
there is a lag.
intraoperative
Let
mouth
me
opening.
capture the video.
Mouth opening.
You can go one slide back, sir. Back,
So-
back, sir. One slide back. One slide back.
Back, okay. I've done one slide back. I've cut off my video.
Yes,
so
sir. Yes, sir. This is the.
I
This is
cut
the.
intra-op.
This slide is showing the. Yes, sir. 30
Now,
mm.
yeah. Now we have the post-op CT.
Yes.
Yes, sir.
Yes, we can see that.
And that is now finally post-op result, and we'll try and play a video of him trying to eat comfortably a fruit. About 3-4
Did you
weeks.
consider getting an MRI, sir, to just check that the disc is in place at the new joint space? Or
We didn't. There are two things, sir. One is the disc is going to be damaged. It is going to be a head which is fused there. But now pre-operatively we have a nice joint space on top.
yeah,
So the problem is the attachment of the medial pole to the mandible is very thin. When we are manipulating to retrieve the disc or something, we didn't want to end up that.
okay.
If that goes, then we are going to have a retruded mandible, and we need to have a joint or a bone. So we need to reconstruct the joint and do a deformity correction. Otherwise, OSA is going to become worse. So we didn't worry about the disc because the movement was free intra-op also. We didn't even have to resort to temporalis release. So once it was, so the temporalis were there. So then we realized, so we can try and give him. So there is a nice top, and there is a nice joint architecture is fine. There's no damage to the joint surface as well. This just to show that he's okay with the facial palsy also.
Facial. Yes, yes. That's a nice case.
Yes, yes, yes. Wonderful.
So now, as you said, technology is only helping us, sir. Otherwise, we will be struggling with this. Meaning, it
Just a
you
left
will
field view, sir. Would you consider doing a closing wedge of that and getting it back into the glenoid fossa? Or it's too much to think about?
now probably no. Now probably no. Because he
Oh.
was holding position. One good thing is in the model which we saw that after taking this with a
Yes.
little play, we try and open and see, but it's in a closed position. Well, opening and
Yes.
closing, it's difficult to replicate in a model. But advantage is
right.
it's in closed position. That is how it will end up anyway.
Agreed. Point taken.
Thank you, sir. I'll end my.
Thank you, sir. Now I request Bhattacharya, sir.
Yeah, I have certain questions and some comments. First of all, I think the postgraduates have presented very well.
Thank you.
But at the same time, I would like to ask you, you said Sani's classification. Who is Sani? Who was Sani?
Sir,
See,
they are
this is
very
the
young.
problem.
They are very young ones, sir.
No. If they can remember the
Yeah.
centuries back names of abroad,
Foreigners.
Sani, they must know and
We
go
do
and
stand on
read.
the shoulders of giants.
He
Yeah.
is a giant.
Yeah.
He was a giant. Recently, he has left us. Okay.
Yes, Soundarya ma'am and Sakshi beta. Do you know CP Sani, sir?
You must appreciate the Indian contributions.
Absolutely.
And what was, apart from classification, what else he did in TM ankylosis? He was the first person to use implant, silicon implant. And he showed long-term result that implant doesn't work very nicely. They have a tendency to come out. Okay. But anything new, he did it. Second thing is, what is Brisbane therapy? Second team can answer.
Team 2. Team 2. Sonali and Sonali. They are here. Team 2.
I think team 2 is answering.
Yes, sir.
Yes. What is
Yeah,
Brisbane
Sayali.
therapy?
Sorry, sir, even we don't know the answer to it, sir.
Okay.
So Brisbane therapy is done when there is a fibrous ankylosis. So you have to diagnose whether it's a bony ankylosis or fibrous ankylosis, unilateral or bilateral. And it is nothing but forceful opening of the mouth under GA. That means you introduce the Ferguson's mouth opener, and if it is fibrous ankylosis, you will be able to tear the fibrous part. And the mouth will open without much surgery. Okay. And then they have to do the physiotherapy. Now, in the controversy remains that if there is a unilateral or bilateral subcondylar fracture, extracapsular, will you reduce and put a plate or not? Maybe a 2-hole titanium plate or not?
For subcondylar fracture.
Or subcondylar, extracapsular fracture,
Yes, sir. We will reduce and fix.
you will
If it is
reduce and fix.
displaced.
Yes.
Because I think that should be the answer, because even in CMEs I have heard, even very experienced people from country and abroad, they say that I will better leave it. I'll better leave it, which I don't agree to. You should have an anatomical reduction and fixation. The danger is facial nerve and the internal maxillary artery. Now, how do you avoid then damage to the internal maxillary artery from the beginning?
Yes, sir. So first would be knowing our surgical anatomy well and knowing the bony.
You don't know. You don't know. There may be variations.
Okay, sir.
How do you prevent technically internal maxillary artery damage?
So we can place a small retractor just medial to the condyle.
Answer is, from the beginning, you do subperiosteal dissection all around. So when you go posteriorly, automatically internal maxillary artery is pushed.
Right.
So the chance of damage is less. And when you use the gadgets, the chance of damage is more, because sometimes when you are cutting the neck of the condyle, then suddenly the resistance goes out as you have cut the bone. So many people keep cutting about 2/3 and rest they use hammer and chisel. Now, if you have to cut the bone to create a gap arthroplasty or lateral arthroplasty, which segment you will cut first, the lower end or the upper end?
Lower end, sir.
Why? You are correct. Why?
Sir, if we cut the upper end, maxillary artery lies 2 mm near the
No,
next
nothing
to
to do with maxillary artery.
maybe it's easier.
Mandible is a still a mobile segment. It would give us a more stable chunk
because
of
the higher, because the upper part is
Yes,
fixed.
yes, sir. It is
Okay.
more fixed.
If you cut the upper first, then it
Then
becomes
that-
flail.
Yes,
It's
sir.
very difficult to cut the lower end.
Yes.
Now, what is the landmark? Many a times in long-standing cases like this, which we presented, the joint line is completely gone. How do you identify the joint line? What is the landmark, surface landmark?
Sir, the upper landmark would be the lower border of the zygomatic arch, sir.
That is bony part. I'm talking surface landmark.
From the middle cranial fossa till the lower bond, 0.2 centimeters.
You draw a line in front of the tragus.
Right.
You put your finger and find out yourself just now. You draw a line in front of tragus. That is the joint line. As simple as that. Okay? And then you make a mark with any instrument you want. Then you will not be entering the middle cranial fossa.
Yes, sir.
Now, when why there is a bilateral fracture? What was the nature of vector of the trauma? I saw the plates in the symphyseal parasymphyseal area.
Yes, sir.
So why it is not unilateral? Why it is bilateral?
Sir, it would have been typically what we called as a guardsman's fracture or a parade ground fracture, sir, where the patient has impact over
Blow in the chin.
the direct blow would be at the chin, leading to symphysis or parasymphyseal fracture and bilateral condylar fracture.
Transmission of force.
The answer is the direction of the force. If it is in the center of the chin, the force goes on both sides.
Yes, sir.
So the chance of bilateral is more. If it is a tangential on one side, then the opposite side fracture will occur.
Yes, sir.
Okay.
Yes.
Now in all these, patient wants mouth opening. Okay.
Yes, sir.
So when you say create a gap, whether there's a gap arthroplasty, lateral arthroplasty, it's a pseudo joint. Pseudo joint is forming.
Yes,
Okay.
sir. Yes, sir.
So how do you maintain that pseudo joint? What will tell the patient so that there is no re-ankylosis?
Sir, active movement is needed, sir. Good post-operative exercises, post-operative aggressive physiotherapy is.
Okay. Suppose you do post-operative physiotherapy and you want to put a bite block.
Yes, sir.
Okay. So that the mouth remains open. Where will you put the bite block?
Sir,
In between incisor, canine, premolar, molar, where?
Molar region, sir.
Why?
Sir, it opens up.
Sir, that would give the
opening of the
most
condyle.
maximum translatory movement of the pseudo joint as well, sir, as opposed to.
That is the fulcrum of mandible.
Yes.
If you put in the incisor, it will go up.
Yes.
Okay. So
Yes.
whatever you have created will go,
Right, sir.
will be destroyed. So that is the fulcrum of mandible. You must know the principle.
Yes, sir.
As far as intubation is concerned, again, blind nasal intubation, those who know, they are masters. And we have seen all sorts of latest technology with fiber optic and ultrasound. They take much more time, number one, and they introduce several times because they are not yet well trained. And then there is a ego that I'm having a fiber optic, why can't I intubate? And when they keep on poking, and ultimately may succeed, but patient belongs to us. And then there's a huge post-op laryngeal edema. We have seen these complications. So tell them that you can use it, but not too many times maybe. Okay. And we have seen all these complications. I'm speaking from my own experience. So blind nasal intubation, sometimes, they have a small light source at the tip. And you can actually see where it is going from the surface only. Even all of us can see from a surface that where he is going. As soon as he enters the trachea, the larynx, immediately there's a spasm. And that proves that he's in. All of us can say he is in. This happens in routine intubation also. And to the faculty, I would like to know interposition arthroplasty versus gap arthroplasty. What do they prefer? Because interposition means either a bone block or a temporoparietal fascia, which is not a fixed structure. We are interpositioning fine. But once you have created a gap arthroplasty, how much bone block you want to remove to the students?
Sir, at least 1.5 to 2 millimeter of block should be removed. Centimeter.
No. Make it centimeter.
Yes,
There's
centimeter.
no role of millimeter.
Sorry, I meant centimeters.
Okay.
1.5 to 2 centimeters.
Yes. So many a times, when you put all sorts of things have been done, the head of the metatarsal or the head of fibula and all that. Okay, deep tissue transfer. But what should be done? Interposition, soft tissue, or bony block?
Soft tissue interposition is better, sir, because so soft tissue interposition would be better as compared to bony block, sir, because bone can again re-ankylose the joint again, sir. So
Yes.
soft tissue.
Yes, because from day 2, next day we start physiotherapy. And I'm telling you, if physiotherapy is the key to the success, whatever you have done on the table. And you have to insist that because they're having little pain and you can manage that. But that is the key. And that has to be continued throughout, for at least 3 months or so. Because a pseudo joint is forming. And when I treat them and I threat them that if you come again re-ankylosed, I'm not going to leave you. When they enter next time, the OPD, they come like this, mouth opening and closing from the door itself. That yes, sir, I got it. Okay, and they are happy to do it. So I think the most important aspect post-op is the physiotherapy. I think I just wanted to mention these things from my experience. Thank you so much for giving the opportunity.
Thank you so much, sir.
Thank you, sir. Now I request Dr. Tahir. Dr. Tahir?
Yes, sir.
Yes, can you carry on for the next case?
Yeah. So Dr. Saheli and Dr. Saheli will be presenting the next case. It is a case of hemifacial microsomia and testial flare. Dr. Saheli, could you share your screen now?
Yes, sir, we are sharing.
The panelist for this session is Dr. Priyankar Singh. And
You can make it full screen. Dr. Sayali? Yeah.
We have made it full screen.
yes, please start
Please
with the
start.
Yes.
You can start your video also, yeah.
Yes. So we are not able to change the slides.
You can go back and share screen again. Yeah, just try whether they are moving or not.
No, sir, they are not moving. They are trying to exit.
Exit your full screen mode and you can continue the presentation.
Actually, you can just exit the full screen mode and reshare the screen.
Yeah.
Sir, is it visible?
Yes, yes.
Yes, now we can see.
Just try for whether they are moving or not. Slides now.
Sir, it again stopped.
There is some problem.
Can you see the
If
presentation?
you,
Yes, keep
yeah,
it like this and now keep
it
on
is
going
good.
down.
If you can move like this, just move on.
Okay,
If you
sir.
can move like this, just try.
Yes, sir. Sir,
Just try. Go on moving. Yeah, yeah. You can keep it like that.
yeah. Yes,
Just
sir.
go to first slide.
Yeah, it's okay,
Go to
Sayali.
first slide.
Present like that only if it is there.
Okay, sir. So, the 2.5-month-old male presented with the parents complaining of asymmetry of face and unable to breastfeed since birth. Patient was born with a defect of cleft of face and had difficulty in breastfeeding. Patient was born with a patent foramen ovale of 3 mm, for which no surgical intervention was done. There is no past surgical history. Patient has one elder sibling with no similar complaints. On examination, there's a facial asymmetry on the left side of the face involving upper, middle, and the lower third of the face. Cleft extending from the oral commissure to approximately 3 centimeter in front of the tragus. There's a microstomia present. There's a soft tissue rising present distal to the cleft of approximately 3 centimeter in length. There's a deformity on the left temporal region, which can be seen in the next slide. There's a nasal asymmetry. There's a deviated nasal septum towards the non-cleft side. There's a broadened nasal dorsum. Difference in the level of the L of the nose. The cleft side is quite higher than the non-cleft side. On the ear, there is a cleft present on the left tragus. There's an accentuated epicanthal fold present on the cleft side, and hypertelorism is present. Patient then again presented at the age of 4.5 years. At this stage, there was a gross facial asymmetry present. There was a midline shift towards the affected side. There was hypoplastic soft tissue present on the affected side. There was malar flattening on affected side. This chin deviated towards the affected side. And there's a sparse hair on the left medial eyebrow, and temporal hallowing can be seen on the left affected side. Hypertelorism is also present. Interpupillary distance was 78 mm and intercanthal distance was of 42 mm. No, there's a nasal asymmetry present, deviated nasal septum to the non-affected side. Nasal dorsum widening is also present, and nasal hump can be seen on the cleft side. The scar of previous surgery present on the left corner of the mouth. The patient was operated for tasier cleft. On intraoral examination, the patient has adequate mouth opening. There's a deviation of mandible towards the left side on opening the mouth. There's no cleft of hard and soft palate or the alveolus. We would like to see for the maxillary any supernumerary teeth or maxillary duplication and occlusal cant in the patient. The further examinations that we would like to do for this patient, for general examination, we would like to see for the any vertebral or limb anomalies. For extraoral assessment, facial nerve assessment, we would like to do palpation of bilateral condyles and its movements. We would like to palpate the bilateral zygoma arch, supraorbital rim and infraorbital rim, temporal and frontal bone. We would like to assess the function of muscles of mastication. Intraorally, we would like to see for the dentition of the patient, occlusion and hard and soft palate alveolar clefts. Investigations that we would like to do for this patient is 3D scan of the face or OPG to check for any dental involvement, condylar or coronoid deformity, mandibular hypoplasia, MRI for soft tissue assessment and TMJ status, hearing assessment, audiometry. Audiometry was done for this patient, and patient has mild hearing impairment with left ear. And lacrimal flow assessment, we'd like to check for the latency of the lacrimal puncta. So 3D CT was done at the age of 2.5 month old, and patient was 2.5 months. We can see left mandibular hypoplasia. The mandible is deviated towards the left and it is tilted downwards on the left side. There's a missing coronoid process on the affected side. Abnormal shape of the left ramus, condyle, and the genial fossa. Occlusal candida is present. Left maxillary hypoplasia can be seen. Underdeveloped legs, left zygoma. Notching present over the left medial supraorbital rim. Left orbit is displayed superiorly. So for this patient, the diagnosis that we would like to give is for hemifacial microsomia, Goldenhar syndrome, type 2B as Kaban's-Brzezinski's classification. Tessier cleft 7.1B, according to Butto's and Botha's classification, since there is a temporozygomatic cleft. Tessier cleft 3 and 11 for the oculonasal and medial orbitomaxillary cleft. And Tessier cleft 13, the soft tissue clefting that which is present on the left side. For the management of these patients, the problems that are to be addressed are the management of the soft tissue component, that is Tessier cleft 7, management of the skeletal component, correction of contour deformity at the left malar prominence, and reconstruction of TMJ, management of functional problem to achieve alignment of the dentoalveolar arch in both maxilla and mandible in midline, and also with the mid-sagittal plane. Management of hemifacial microsomia with Tessier cleft 7. So at the infancy period, that is 0 to 12 months, the soft tissue management has to be done. So Tessier cleft 7 has to be repaired. At the age of 6 to 16 years, at childhood and adolescence, the management that we would like to do is for mandibular deficiency, distraction osteogenesis, and for orbitozygomatic deficiency, costochondral reconstruction or calvarial graft, and orthofunctional therapy for dental and occlusal alignment. At the age of 17 or more than 17 years, for maxillomandibular distraction, osteogenesis for final correction, fixed orthodontic therapy for occlusion, and osteotomy for asymmetry correction.
Thank you, Sally. Thank you, Sally. So I now invite our panelists for this session. Dr. Priyankar.
Hi, good evening. I am Dr. Priyankar Singh.
Yeah.
A very in detailed presentation, both Sally, in fact. So let us start with the very basic of it. Like, considering the patient, every profile, I guess you both would have realized that this patient needs a comprehensive treatment, starting from the soft tissue construction, then to the bony reconstruction at the later part. But let us start from the beginning. Can you just briefly tell about all the Tessier classifications and why you put it in the given criteria which you have put so now?
So the Tessier class 1 has there's the 0 is the median, and 1 is the naso. One is the paramedian cleft, then cleft 2 is the middle third of the nostril rim. Tessier 3 is the oculonasal cleft, which has the medial orbitomaxillary clefting. Then Tessier 4 is the orofacial cleft with the lateral orbito-maxillary cleft. Then Tessier 5 is the lateral orbito-maxillary cleft. Tessier 7, in which there's a clefting of the zygomatico-maxillary cleft. The cleft for this patient, the cleft Tessier 7, since the cleft is starting from the corner of the mouth to going towards the tragus of the ear. Then cleft 8 is the frontozygomatic cleft. Then Tessier 9 is the upper lateral orbital cleft. 10 is the medial upper medial orbital cleft. Then 11 is the central. 10 is the medial cleft. 11 is the 10 is the central, and the 11 is the medial cleft, and the 12 is the cleft of the ethmoid and the glabella.
Okay, almost accurate. Good. So if you just see the Tessier classification, it just take a half turn from midline, and it involves almost every corner of the face, including the soft tissue and the bone. And as per the given line where it is involved, we give a particular number to it. So the case which you have presented, that comes under the criteria of Tessier 7, which is also known as
Zygomatico-temporal cleft, sir.
okay.
Zygomatico-maxillary cleft.
Okay, good. Or auriculo-vertebral cleft.
Oculo-vertebral cleft.
Okay, good. So which all brachial arches do you feel that that may be involved, or which causes that?
So first and the second brachial
First and second. Okay. Now just considering the first clinical look, what all muscles of the face do you think would have been and got involved in that lateral part?
The temporalis muscle and the
Starting from the corner of the lip.
So orbicularis oris, buccinator, zygomaticus major, risorius. The cleft usually ends at the anterior to the temporalis muscle, sir.
If it stretches till there.
Masseter.
Okay. And as we classified it on the basis of Tessier, do you think there is any other particular classification for Tessier 7 or the lateral cleft, which only defines or speaks more about that?
So Buto and Botha's
Very
classification.
good. Very good. Buto and Botha's classification. And into how many criteria it has classified it?
Sir, based on the presence of the angulation of the cleft, that is, it is either
Angulation of the cleft.
vertically or laterally or the inferiorly displaced.
Inferiorly. So it's just 3 lines, one passing through the midline of the commissure of the lip, one above and one down, based on the angulation.
Yes.
Almost rotating and involving around the modulus. Okay. And what all syndromes which you feel that could be attached with the Tessier 7 part?
Sir,
golden syndrome, hemifacial microsomia,
Tessier's Treacher-Collins syndrome, but since there's no bilateral involvement, we can rule out the Tessier's Treacher-Collins syndrome.
Okay. So what are the So what are the primary complaints which you can feel that, like, every orofacial cleft baby has got it, but what are the primary features which you can feel that the baby would be suffering from? The functional part.
Difficulty in
there might difficulty in feeding, suckling mechanism would be affected, and then hearing impairment may be present. Also, this baby doesn't have, but respiratory impairment might also be present. Coming to function
Good.
and speech.
Now, as you mentioned in your PPT presentation, that the child has PFO, right? Patent foramen ovale?
Yes, sir.
Okay. So what all associated congenital anomalies can you think along with it? Or other cardiac anomalies also which are associated with that?
Teratology of palate may be present.
Yes, I will come I'll come by around
And
Very commonly we see ASD, VSD also attached to that.
yes, PDA, patent ductus arteriosus may be present. Vertical septal defects.
Okay, these are cardiac. Any other facial congenital anomaly can you see with it? Do you see any tags on the face along with that most of the time?
Preauricular tags may be present, sir.
Okay. And there could also be atresia in that.
Yes, sir.
Okay.
Yes. External
So
and internal.
Very good. Okay. So can we just go to the that picture, intraoperative picture?
So intraoperative pictures we have not added in the slide, sir.
Okay, there was one intraoperative actually. So when we are operating it, what all layers do you feel that we are going to handle? And again, the sequence inside out or outside in?
Outside in.
We'll go outside in. Preferably, we try to construct or reconstruct the buccal mucosa part.
Yeah.
We try to remove the extra tissue. We try to remold the tissue in the buccal areas. And before starting, the first point which you have to consider is the markings. Our first priority is not only to reconstruct the buccal part inside or the facial skin part outside along with the muscles inside, but also considering the contralateral part of the commissure of the lip, and we have to just replicate it exactly. So in this, which area will you consider for standard marking part? Which part of the face?
Filtral commissural length of the unaffected side will be transposed on the.
We'll simply, yeah, exactly. We'll simply consider the unaffected part of the lip, and from the filtral column, we'll measure the commissure of the lip area, and we'll just try to replicate it on the other side.
Yes.
Okay. So what all are the layers which you feel that we are about to reconstructing? And again, the technique is from Buto and Botha only.
Sir, the commissural 1 million commissural flap is raised on the upper lip and the lower lip.
Trilaminar closure of the cleft will be done, sir. Where the mucosa, the skin, the subcutaneous tissue, the muscles, that is the depressive angular muscle, the buccinator muscle, and muscles are pulled and they are sutured, and then the mucosal layers.
Okay, so basically it is in 4 layers, as we see. We first try to start from the buccal layer part. We try to reconstruct the buccal mucosa. While reconstructing the buccal mucosa, when we come to the commissure of the lip, we may take various flaps, the local flaps, to rotate and reshape the commissure part so that it should not be very much contracted. And we just try to replicate the length to the contralateral side. While doing so, at the same time, we also replicate the upper and lower muscles, and we try to not exactly, but rebuild it. And then finally, the skin part. If I'm talking in terms of the PG part, from a PG point of view. So when we are doing the skin part, do you think we can do some plasties over there?
Yes, sir. Z plasty or a W plasty.
Or a simple straight line closure also, most of the time people prefer that. Okay. Yes, so these are basically the ways we generally try to close a Tessier 7. Now, if you see the post-op, the baby has come after 4 years. What is a very prominent feature which you are looking at the nose area?
So the difference in the level of the ala and there's a nasal hump present on the left side.
Okay, what is the normal interpupillary distance?
Sir, interpupillary 60, sir.
And
60
intercanthal?
Sir,
60
30
what? 60?
mm.
Okay. So the average interpupillary comes around 6.3 to 6.7. And the intercanthal is around?
35 mm, sir.
Okay. 2.5, almost we take it as a average mark. So considering this patient, do you feel that the interpupillary and the intercanthal distance are normal in this baby?
No,
No,
sir,
sir,
they
they
increased.
So what exact clinical thing which we can think of it if the interpupillary distance and the intercanthal is increased?
Hypertelorism, sir.
Hypertelorism. Good. And what are the other special features which you can see? Can you see the medial canthal area of the child in the left eye? It is drooped.
Yes, sir. Yes, sir. So there is a accentuated epicanthal fold can be seen, sir.
Okay. But if we just see, do you feel that the commissure of the lip on the affected side is almost equal or near normal to the normal side which was there?
slightly extended laterally.
Okay. And what all complications which you can assume which could have occurred leading to the facial pull on the normal side? The simple facial nerve pulses could have occurred?
Yes, sir.
Yes, sir.
Okay. Now, since you can you just go back to your slide where you have classified it, the hemifacial part in terms of Brzezinski and Kaman?
Yes, sir.
Okay, very briefly, can we go through all the Brzezinski and Kaman basic classification?
Yes, sir. In type 1, the condyle ramus unit, it is hypoplastic, whereas in type 2B, in type 1 it is hypoplastic but of normal shape. However, in type 2B, there is abnormal shape of there are two classification in type 2. Type 2A, where there is abnormal shape of the TMJ unit, whereas in type 2B, there is agenesis, there is deformity of the TMJ unit, and in type 4, in type 3, there is complete absence of the unit, sir.
So if you now go back to the CT scan of this child, the previous one, on the affected side, the ramal height and even the mandible is very much affected. So would you still like to put it in
Yes,
2B
sir.
criteria?
Yes, sir.
Okay, just give a valid reason for that.
Famous. But there is no complete absence of TMJ unit, so 3 will be excluded. Then for type 2A, there's a agenesis. The coronoid is completely absent as in the this patient.
And even the glenoid fossa
is
and
also not
is absent, but there is deformed condyle which can be seen, sir, and the ramus is also not completely formed.
Okay. So this is basically all about the Tessia 7 and you guys have presented well. I just leave the house open for the other panelists and Bhattacharya sir if they would like to add something.
Surajit sir.
Okay, besides these two classifications, suggest a better classification. A classification which is like TNM classification. T1, T2, T3, N1, N2, N3. So here in craniofacial microsomia, and stop calling it hemifacial microsomia. For the last 30 years, we are calling it craniofacial microsomia, unilateral and bilateral. Hemifacial microsomia is an obsolete term. So suggest a classification which gives each and every characteristic of craniofacial microsomia.
Sir,
Okay,
there is
what is it?
women's classification, sir.
It doesn't do that. Okay, so this is homework. You're going to read it up. The classification is by David, Mahathurmat, and Cooter. David, Mahathurmat, and Cooter.
Okay, sir.
And it is called SAT classification.
That
S is
classification.
for skeleton, A
Skeletal
is for auricular anomaly,
auricular
and T is for
soft
soft
tissue.
tissue.
Yes.
And the classification is such that it tells you what has to be done. That is what the classification should be. That is what TNM classification does. It tells me what has to be done. And in whichever part of the world I am sitting, if you give me this, it is S3, T3, A1 lesion, I at once know what you are talking about. So that sort of transparency, these classifications do not bring, which David, Mathurmat, and Cooter bring. Okay. Then you completely missed telecanthus in your examination. You had to be pointed out. It was a 212 cleft. It was a Tessier 212 cleft. The middle third of the nostril and extending cranially up. That is why there was a telecanthus. There are two cranial clefts side by side. And that is what confused you, isn't it?
Yes, sir.
There is one which is going through the medial canthus, and there is one medial to it, which is causing the telecanthus. So there are two 12 clefts. That is what happened with it. Okay. Now, the third thing which I would like to know from you is that your schedule of if the child came on day one, what are the things that you are going to do first? What you are going to do next? So what is the timetable for managing patients of craniofacial microsomia?
Sir, when the baby will report at 0 to at infancy, I would like to see first if the breathing is assess for his respiration,
Right?
which will be important, and also hearing. I would like to evaluate, sir, and
Hearing
speech,
at that
feeding,
age is impossible.
feeding, sir. If the
Breathing is all right. Hearing is not on. How can you do an audiometry in a newborn child? That is not on. So, what else?
airway, and then if he has any cardiac anomaly also,
Right.
urinary, if any
Other
anomaly is
congenital
present.
anomalies that can accompany.
Yes.
That would be the first thing to do. That would be the first thing to do. Accompanying clefts, their management should start. So if it is a macrostoma, the management should start. If it is a traditional cleft lip and palate, that management should start. So the advice about feeding, advice about immunization, all these stuff at the beginning. Then the auricle in this child is absolutely all right, isn't it?
Yes, sir. Yes, sir.
So you don't have to bother about the reconstruction of the ear. The reconstruction of the ear should happen before the cartilages become bone. So we have to do that. Has to be interspread there. then we'll take away the small tidbits of preauricular tags and address the macrostoma. We'll address the macrostoma. It was detailed to you in great length. Then when do you start that distraction histiogenesis? At what age are you going to start distraction histiogenesis? That was your plan. That was your plan, na? Right? Yes, yes.
This is when the permanent dentition comes in the growing age, sir.
No, when we
Seven.
can identify the tooth buds, we can start,
Okay, sir.
right? So that would be better, what you are saying. But in a severe patient, when it will help in us, we can start a bit earlier. Fair enough. And then what? What are we going to do with these other congenital anomalies? The child is still not all right, so we have to address the telecanthus. What do you plan to do for the telecanthus?
No, partition was
Oh, bipartition.
bipartition.
This is the we have to remove some. So it is not just bipartition;
Yes,
it is osteotomy as well. Fair enough. Leave that. That part is not what I was interested more in, the soft tissue management. Soft tissue management of telecanthus. What do we do? What is the surgery called? Jumping jack something.
We do.
What is that called?
Meeting.
Team 1 can answer. Team 1.
Your left
Okay.
coronoid process is missing. If the left coronoid process is missing, does it need a growth center? Will it be enough to continue with distraction histiogenesis?
Costochondral
Grafting also we'll have to do some.
We'll have to do a costochondral graft. So
Yes,
when we
yes.
have to do a costochondral graft, that has to be done before the child becomes mature. We want this end to grow. So this should be done somewhere around 4 to 5 years of age. Let us do something to the graft. Give it a growing condyle. Okay. We can continue now.
Thank you, sir. Dr. Priyanka, sir, you want to add something more? Bhattacharya, sir.
No, it's okay. If Bhattacharya sir would like to add anything more to it,
Yeah.
Anand sir?
See,
No.
first of all, you must understand that the purpose of any classification, all these things are classified by different people in a different way, but they keep in mind the purpose is how does the classification helps the management. So that is one of the major purpose of classification. The patient's parent will come and ask you, and therefore I am asking you, how many operations this patient will require? What will be your answer? You have to unmute. You have to unmute. Yeah.
Sir, the patient will require multiple surgeries, sir.
How many?
So one.
I am the parent. I am
patient
asking you how many.
So one for the facial cleft and closure, and then for the costochondral grafting will be the second procedure. And
You have
in
not yet answered me. How many I am asking?
Sir, what
Please.
number? Sir, what number? Right, sir?
5.
5, 6, 4.
5.
Team 2?
5.
5.
Team 1.
5, sir.
So if you can do it in 5, no, you will get a Nobel Prize. Okay. You have to convince the parents that it will require innumerable number, but patient should not run away at the same time. To convince them, you have to say that every time there will be significant improvement. And as the child grows, it will require innumerable surgeries. You should not put the number. You should convince them that you will improve every time significantly. And therefore, you have to have in mind a sequence of events. And to have this sequence of events, you alone cannot do it. You have to have an elaborate team. Therefore, such patients cannot be managed in a primary, secondary center. It has to be in a tertiary center. And all the team members will sit and decide the sequence. Okay. So it is a very complicated situations, and therefore you have to give your best. Even then, ultimately, people can make out something has been done at the age of 40 also. Okay. So you may reach near normal, but you have to convince them, see, it will be near normal. He will be like most of us. All of us look differently. Therefore, he will look also little different. But this sequence of events has to be decided by the whole team. This is very essential in the when you are doing the counseling. Otherwise, these patients will not be satisfied and they may go to some other place. Now, why don't you call it distraction osteogenesis? You are distracting the bone, no? You are
Yes, sir.
making the cut in the bone, but then why
Yes,
don't you call it distraction osteogenesis? Why are you calling it
It is
distraction histogenesis?
because simultaneously even soft tissue changes take place when the bone is distracted.
Yes, because the soft tissues are attached to bone.
Yes.
So the moment you do and they affect each other. The movement of the even bony distraction will be guided to some extent by the soft tissues attached to them and the muscles, the strong strength of the muscles and how strong they are. And therefore, it is histogenesis. And where are the growth centers of mandible?
Condyle, sir.
That's all. Dr. Surajit was mentioning. I thought he will be asking also.
Coronoid, sir.
Where that Dr. Surajit already said. So luckily you remembered it. Where else? Condyle, coronoid.
Posterior border of the ramus chin, the symphysis.
Now you are guessing. Other team?
Sir, three primary growth centers, sir. First is the condyle, the coronoid process, and also the symphysis region is the growth center. Secondary growth centers will include mental foramen area, alveolar bone, and also the basal bone, sir. That changes along with the growth of the primary centers. Those will be the secondary centers.
So one more you are missing. See, if you visualize the mandible, there is a condyle, there is a coronoid process, then there is a ramus, and then there is a body. And all these four segments have growth centers of different magnitude and their potential. So condyle gives the vertical as well as there is an angle of mandible which decides primarily the growth of the height of the ramus and coronoid process and parasymphyseal near the mental foramen. So there are four. condyle, coronoid, angle of mandible, and parasymphyseal or the mental area. Okay. So there are 4 growth centers, but the most dominant one is condyle. Condyle. Thank you.
Thank you, sir.
Why was it called golden hour syndrome? What is golden hour syndrome?
So because it is oculo-auriculovertebral syndrome.
And
Bec-
what was the ocular clinical finding in this? Did you see a epibulbar dermoid?
no, sir.
No ocular
Then it is
findings.
not golden hour. Then it is not golden hour. Golden hour and regular craniofacial microsomia are 2 different diseases. Golden hour is genetically transmitted, whereas the craniofacial microsomia is most of the time not. So golden hour has a stronger autosomal dominance. Golden hour syndrome has epibulbar dermoids. When there are no epibulbar dermoids in the eye, it is simply craniofacial microsomia, not golden hour syndrome.
Thank you, sir.
Good.
Can we now invite our judges for the comments? Madam Abhilasha, Mustafa sir.
Farooq, something is happening to your mic. Something is
The voice
happening to
is
your mic,
speaking
Farooq.
actually.
Voice is not clear.
No,
The voice is
something
speaking, sir.
is going on.
Okay, now I invite our judges for the final comments about today's session.
I think both teams have presented very well and it's been extensively discussed. I don't think there's anything more that I have to add, sir.
Thank you, sir.
Thank you.
Abbas sir is there?
Yeah, I'm there.
Yes, sir.
Yeah, nothing, but I think the discussion went on very well. So no further question.
Thank you, sir.
Okay.
If all is done, so at the end, I request Dr. Tahir for the vote of thanks and the final. Dr. Tahir.
Yes, sir. Thank you so much, sir. So, sir, with this, should we give some time for the spotters? I think we have a few spotters.
Yeah, why not? Why not? If spotters are there, we can give time.
So, sir, I'll share my screen if Dr. Priyankar sir is willing to ask a few questions on the spotter.
Yeah, Dr.
Sure,
Tahir,
sure.
you can share the PPT and we can ask all the panelists to even ask on the same.
Sure.
Because we still have around 5-7 minutes. So if
Sure, you can go ahead.
yes, sir. So I think, sir, we'll start with a. So should we start with this case, sir?
Okay, team 1.
Yes, sir. Sir,
Ankylosis case.
so this appears to be a case of TMJ ankylosis, but since we don't have the other side of the CT, can't comment
Bilateral or
whether it is a bilateral or unilateral, sir. It looks like a unilateral ankylosis only, sir.
One side
There
ramus
is
shortening.
deviation of the mandible towards the left side. Unilateral TMJ ankylosis on the right, left side. Ramal shortening on the left side, sir, that is the ipsilateral side, deviation of the chin and the mandible towards the affected side. A pediatric patient
Then pronounced antigonial notch is also there
on the 3D CT, sir.
3D CT.
on the affected side. Age of the patient.
Team 2, would you like to add
11
something to it?
years, I think. 11 years.
Bird's face deformity can also be appreciated, with more appreciated from the lateral profile, sir. There is a reduction in the lower third height of the face, sir. And we can see the lips are also incompetent.
Okay, quick steps for the comprehensive management. And the word is comprehensive management.
Sir, since this is a pediatric patient, 11 years of age, sir, first would be to, and it's a unilateral ankylosis case, sir. We can go ahead with treatment that is commonly followed. The Kaban's protocol can be done, sir. Unilateral ankylotic mass release followed by ipsilateral coronoidectomy. If adequate mouth opening is not achieved, then contralateral coronoidectomy. Interpositional grafting with either
Fascia or disc.
fascia or articular disc, but in this case, it's highly doubtful that the articular disc might be still viable and present. And sir, a ramus condylar unit reconstruction can also be done with a costochondral graft in this case, sir, in order to re-establish the height of the ramus as well as help the growth of the mandible. That would be achieved by the costochondral graft. Yes, sir, and aggressive post-operative physiotherapy.
And suppose if we think to correct the facial deformity and the ankylosis in a conjoined form, and you decide to go for distraction also.
Yes, sir.
So what would be your call? Distraction first and ankylotic mass release later, or release the ankylotic mass and then go for the distraction? Team 2.
Distraction first. Distraction first. And then
To the panelists to add something else?
If Dr. Amarnath would like to ask any questions.
Dr. Anjani is also along with us. He's a very senior cleft and craniofacial surgeon in Muzaffarpur. If he would like to add something to it.
Yeah, please.
Dr. Anjani?
Is he present or I could not see?
He was there in the participant list. Anyways,
I could not see. Maybe he has left.
Maybe.
If any quick word of advice from the great seniors which we have with us. Bhattacharya sir and
We can move to the next case.
okay.
Sir, this is the last case we'll take because I think we are already.
Yeah.
So if team 2 can describe this case, then.
So this patient has an obvious facial asymmetry with that midline which can be seen, which is deviated on the right side, sir, along with chin deviation also present on the right side. There seems that the facial height is reduced on the right side, sir, compared to the left side, sir. And there is mild flatness present on the left side, and fullness on the right side, but it cannot be appreciated in this case, sir. Also, sir, with respect to the OPG, it looks like a well centralized, well exposed OPG, where we can see there is increase in the mandibular bone, body callus height on the left side, sir. And yes, sir. And
If team 1 would like to add something.
So we'll have to see whether it is, sorry, sir. It appears to be a case of hemimandibular hyperplasia, sir, where the left side of the mandible is elongated, leading to deviation of the chin towards the contralateral side. There is characteristic bowing of the lower border of the mandible as well, which is evident on the left side, as well as the elongated ramus of the mandible, condyle as well as ramus. So left side, the entire mandible seems to be that is the half of the mandible seems to be elongated. If we would have had intraoral pictures also, I think occlusal derangement can also support this diagnosis, sir. There might be an open bite, posterior open bite that might be present on the left side.
So Dr. Priyankar sir, would you like to ask something?
No, it's okay. I think we are also running short of time and they've answered almost okay. So
sir, quickly, if you could let us know the management of this.